Hit the subscribe button or visit us at auau.auanet.org.
Good morning, and welcome to Chemotherapy and Immunotherapy for the Urologist and Advanced Practice Provider, presented by the AUA. We strive to offer outstanding educational courses and greatly appreciate your evaluations and general feedback so we can continuously improve our programs. We thank you for joining us. Before we get started, I'd like to go over a few items so you know how to participate in today's event. I'd like to extend a special thank you to our course director, Costas Lawless, for planning an excellent educational course. We thank you for your dedication and commitment to urologic education. Thank you as well to our faculty for their time, talent, and expertise for today's program. The AUA is accredited by the ACCME and designates these other activities, live virtual activities, and enduring materials for a maximum of 2 AMA PRA Category 1 credits. Evaluations are very important to us. Course evaluations and CME credit will be administered electronically on the AUA 2021 site immediately following the live program today. As the AUA continues to develop virtual education that meets your needs, we welcome your feedback regarding both the content and format of this activity. Please visit AUA2021.org to complete your evaluations and credit claim. All persons in a position to control the content of an AUA educational activity are required to disclose any relevant financial relationships with any commercial interest. Please visit AUA2021.org to view Faculty, Education Council, and COI review workgroup disclosures. The American Urological Association would like to thank Amgen, Astellas, AstraZeneca, Bristol Myers Squibb, Janssen Biotech, Inc., administered by Janssen Scientific Affairs, Merck, Pfizer, and Sanofi Genzyme for their generous support of this educational program. This activity is meant to be educational in nature and in some instances reflects the opinions of the presenters. The information does not guarantee accuracy of claims submitted. Please verify the accuracy of individual medical claims submitted and please follow individual insurers' rules. It is my pleasure to introduce our course director, Dr. Costas Lawless. Dr. Costas Lawless is a professor and vice chair of education in urology at the Sidney Kimmel Medical College of Thomas Jefferson University. His clinical practice is in urologic oncology, focusing on minimally invasive techniques. He is a member of multidisciplinary management teams in urologic oncology and renal transplantation at TJUH. He serves as the Director of Robotic Surgery and the Director of Surgical Simulation for TJU and TJUH. I will now turn the program over to Dr. Lawless.
Good afternoon and welcome. I'd like to thank the AUA for allowing us to present our course again this year in a virtual format. This is our 5th year presenting the course, and we still believe it to be very relevant. I would now like to introduce our faculty. First, Dr. Ann E. Lizardi-Calvaresi. She works with us here in Philadelphia as a nurse practitioner and director of clinical operations in the Department of Urology at Thomas Jefferson University, where she also completed her Doctor of Nursing program just recently. She also serves as a member of the American Urological Association's Advanced Practice Provider Membership and Education Councils and the Mid-Atlantic American Urological Association APP Committee. Anne has been working with us for several years. She's just coming off a very successful program yesterday, and we're thrilled to have her. Dr. Ed Trabolsi is a professor and vice chair in the Department of Urology of the Sidney Kimmel Medical College at Thomas Jefferson University. His research interests include advanced imaging for prostate and bladder cancer, including enhanced ultrasound and novel PET imaging, as well as appropriate use of postoperative radiotherapy after radical prostatectomy. Ed was the first person I met arriving on Jefferson's campus 16 years ago. He's certainly one of the smartest people I know, knows this subject matter cold, and I'm just thrilled that he's here to join us today. All right. It is now time to get started with our program. Our first speaker is going to be Dr. Ann Calvaresi, who will be speaking on prostate cancer.
Good morning. Thank you for the introduction. So we're going to get started with prostate cancer. We're going to start with this very traditional representation of prostate cancer. So starting on the left with localized prostate cancer, and then going through the progression of the disease, where you might see a biochemical recurrence that historically was treated then with androgen deprivation therapy, moving onward through the castrate-resistant disease, where we would then use advanced systemic therapy. And so we're going to study this again later on this morning and see how this disease progression has changed, and more so where we've seen changes in the therapies that we use along the progression of the disease. And so traditional hormonal ablation therapy is what we've always used. So the GnRH agonists, they stimulate the LH and FSH from the pituitary gland to the testis. With these, you can initially have a spike or a surge in testosterone. So a lot of times you need an androgen block. You see, this is like a negative feedback system. So kind of like your home thermostat on a really warm day, it'll constantly tell the cooling system to cool, and then it'll just kind of shut off. You see these changes with the testicles as well. Most common agents in this class is leuprolide. The GnRH antagonists, these directly inhibit the pituitary LH and FSH release. So you don't see that, that initial surge in the androgens. You don't need to use a blocking agent. Most common class here is degarelix. And with these, you actually see a very quick decline in a matter of days in the level of testosterone. So you would use this in your patient who you really need to drop their testosterone very quickly. The non-steroidal antiandrogens, they block the binding of the androgen to the androgen receptor. Again, this is what you would use when you're using the agonist. These can cause gynecomastia. You can see them used in monotherapy or again in combination with the GnRH treatment. Most common agent here is bicalutamide. With these drugs, you should monitor the LFTs on these medications. Usually I'll order a panel about a month out. You can also see some GI side effects with diarrhea and nausea. Orchiectomy used to be used a lot more commonly than it is here, especially not so much in the US any longer. Here you can see the mechanism of action. Where do these drugs take place? So the GnRH analogs at the level of pituitary, surgical orchiectomy, of course, is at the level of testes, and then the anti-androgens as well. There are varying durations of hormonal therapy. With intermediate risk prostate cancer, you're using that in combination with radiation treatment. So typically you would see patients on this for 6 months. In patients who have high risk but still localized disease, typically they're going to go on treatment for between 18 and 36 months while they're having their radiation treatment. And then in biochemically recurrent and metastatic disease, you can see intermittent or continuous durations. This slide is probably one of my favorite slides at least in the prostate cancer portion of this talk. And this is what I have in my mind when I'm starting someone on androgen deprivation therapy. And I kind of go around clockwise or counterclockwise, what have you, and kind of hit on all of these, because most patients are going to have some, if not all, of the side effects that are listed here. And we're going to go into some detail on these as we move forward. I think that it's really important as nurse practitioners and physician assistants that we take a lot of time in talking with patients who are starting on this treatment to hopefully either minimize or stop the side effects that are associated with ADT. Of course, you're not ever going to stop them, but if you can do some quality of life modifications to minimize the side effects, that's hugely beneficial to the patient. So we worry about cognitive decline. Typically, I think this is more common in patients who are on longer duration therapy, but to minimize the cognitive decline, you want to encourage physical activity. So making sure that they're getting some type of cardiovascular exercise and then also some resistance training. This also helps with their stability. So you worry about patients falling and fractures and the decreased bone health while they're on these agents. If you're having them be more physically active, then they're going to have fewer falls, fewer fractures as a result. Of course, there's altered body composition, metabolic syndrome, and fatigue with these agents. So you want to make sure that they're seeing their PCP on a regular basis, and also a cardiologist if you can get them seeing a cardiologist as well. They're going to need pretty close follow-up for their labs, including their cholesterol panel, glucose, A1C. Again, going back to that daily exercise with aerobic and strength training. Recommending a healthy, well-balanced diet. I usually refer them to the American Cancer Society website or the American Heart Association. They have pretty loose dietary guidelines, but also very helpful guidelines. So if you can go back to the food pyramid that we used to use, some guidelines similar to that. So nothing super strict, but something to help them along the way. You could also consider a nutrition referral if they're really not sure of what to eat and what not to eat. With these patients also, we should use a routine sleep-wake cycle. So going to bed at roughly the same time, waking up at roughly the same time, and decreasing stimulants before bedtime. So caffeine, not taking their laptop to bed, things like that. We touched upon this briefly already, but there is increased cardiovascular morbidity and arterial stiffness. So if they're smokers, try to get them to stop or at least decrease it. Encourage management, again, by a cardiologist. And here's, as I did mention already, the American Heart Association for the dietary guidelines. What I also recommend to patients is to shop on the perimeter of the supermarket. So staying away from those aisles where all of the processed foods are, or where they find things in packages. So I tell them if they're really not sure, don't buy things in packages, buy the freshest things that they can find. Of course, decreasing sodium and alcohol intake is important as well. So these patients are definitely at an increased likelihood for emotional lability and depressed mood. So if you can start managing their side effects initially, that will help with the depression and mood changes as well. Some patients need some antidepressants, some patients need individual counseling. Couples counseling, I think, is strongly indicated in this patient population because one of the biggest factors is the erectile dysfunction and the decreased libido. And so couples counseling, I think, is really, really important. There are support groups available to a lot of prostate cancer patients. And then again, going back to that ED, make sure you can treat it if the patient and or their partner are willing. Hot flashes. This is a very difficult side effect to manage. A lot of the agents that we have available to us for treatment of hot flashes come with their own sets of side effects. You can consider acupuncture, which has much fewer side effects. Anecdotally, vitamin B6 supplementation can be really helpful. And then, we can think about SSRIs or majestrol acetate. I briefly mentioned this earlier, but we worry about bone health in these patients. So I always say it's kind of like when women go through menopause, we see changes in the bone density. So we see decreased bone density, decreased bone health in the presence of androgen deprivation therapy. At the very minimum, patients should be on vitamin D and calcium supplementation. You can see the doses are listed here. You want to seriously consider a DEXA scan, and I think this is underutilized in this patient population. I know myself, I remind myself I should probably get a baseline DEXA on more patients than we do. And then that can be assessed throughout the long-term androgen deprivation therapy administration. In patients who are high risk, that includes the elderly, the smokers or alcohol users, the thin or frail patients, want to consider an antiresorptive agent like denosumab or zoledronic acid. These are really, really strong medications. So patients who are going on them should have a thorough evaluation prior to starting therapy. While the risk is low, there is a risk of osteonecrosis of the jaw. So for patients who need any dental work, that should be done ahead of time, or at the minimum, they should be cleared by their dentist. Uses, again, these are to prevent or treat osteoporosis for patients on androgen deprivation therapy, and it's to prevent and delay the SREs, the skeletal related events, including pathologic fractures. Zoledronic acid is an IV bisphosphonate. It inhibits the bone osteoclast, and this agent's approved for osteoporosis prevention and treatment. So you do need the documentation of that diagnosis. It's given as a 5 milligram IV dose once annually. And then it's also approved for bone mets, and that's given every 3 to 4 weeks. Patients with renal impairment need to be monitored very closely, so their renal function should be checked at pretty routine intervals. The oral bisphosphonates are used much less commonly than they have been in the past. Denosumab, this promotes osteoclast and bone resorption. It minimizes and treats the cancer therapy-induced osteoporosis and minimizes the skeletal-related events in development of bone mets. These patients, the calcium levels need to be watched very closely. You can see hypocalcemia, which of course can be life-threatening. Dosage for patients with existing bone mets, you see them getting treatment every 4 weeks. And then for osteoporosis, they usually get an injection every 6 months. Here you can see the list of agents that we have and the list of studies that have occurred in more recent years. So we do have a lot of agents that are available to us for patients with metastatic castrate-sensitive disease. The ARCHES trial was a randomized phase 3 study of androgen deprivation therapy with enzalutamide or placebo in men with metastatic hormone-sensitive prostate cancer. So we saw a little over 1,100 men with metastatic hormone-sensitive prostate cancer who were randomized to ADT plus Enza or ADT plus placebo, looking at improved overall survival and radiographic progression-free survival. And you can see that that primary endpoint was met. A little over 1,100 men with metastatic castrate-sensitive prostate cancer were randomized additionally to ADT plus Enza versus ADT plus anti-androgen. And overall survival at 3 years was 80% versus 72%. So again, improved PSA progression-free survival and clinical progression-free survival. The TITAN trial looked at a little over 1,000 men with metastatic castrate-sensitive prostate cancer. Again, randomized to ADT plus apalutamide or ADT plus placebo. You can see they're always on ADT. It's kind of a standard, or it is a standard, I should say. Co-primary endpoints looked at improved overall survival and radiographic progression-free survival. Again, these endpoints were met. So you can see the first slide that I showed, much earlier in the disease state, we're using these agents, whereas historically we were waiting for advanced disease in order to incorporate some of these treatments. So all these agents here on the right have been approved for earlier use in the disease progression. In patients with non-metastatic castrate-resistant prostate cancer, so that's a rising PSA in a castrate environment. So their testosterone is all the way down, but their PSA is rising, and their imaging, including conventional imaging, so usually a CT abdomen and pelvis and a bone scan or an MRI in place of the CT, are negative. So we're seeing no metastatic disease on these conventional imaging studies. So the NCCN guidelines include close observation plus ADT. However, there is category 1 evidence supporting apalutamide, enzalutamide, or darolutamide in addition to the ADT. In these patients, you can also consider second or third line hormonal manipulation, as well as flutamide or nilutamide and ketoconazole. So based upon the results from Spartan and Prosper trials, we saw demonstrated metastasis-free survival in men on apalutamide, and in Prosper demonstrated metastasis-free survival in men with Enza. This was the first time this endpoint was used. Huge. So apalutamide, again, approved for non-metastatic castrate-resistant prostate cancer. This is a non-steroidal anti-androgen. It binds directly to the ligand binding domain of the androgen receptor and prevents the androgen receptor translocation, DNA binding androgen receptor mediated transcription. You can see hypothyroidism in these patients, as well as a skin rash. These patients are at an increased risk for fracture. Again, we want to make sure that we're minimizing the fracture, and by maintaining their stability, you're going to decrease falls, decrease fractures in turn. Skin rash, in the patients who I have seen on apalutamide, I have seen skin rash in a pretty good number of them. However, it's usually really well managed with topical topical corticosteroids, or even a little Benadryl is not a bad idea. So darolutamides, next generation androgen receptor inhibitors, it's structurally distinct from apalutamide and enzalutamide, and it's characterized by low blood-brain barrier penetration. So with that, you can see less CNS toxicity and improved tolerability. So the Aramis trial looked at randomization 2-to-1, so patients on 1,200 milligrams of darolutamide plus ADT versus placebo plus ADT, with the final primary analysis at metastasis-free survival and final analysis at overall survival. And you can see those endpoints were met. So 2020 NCCN guidelines for metastatic castrate-resistant disease. Again, maintain that castrate level of testosterone. That's hugely important. You want to make sure that patients who are on androgen deprivation therapy are compliant. So consider a longer duration of leuprolide in patients who are non-compliant or who have to travel a far distance. Again, consider those bone antiresorptive therapies. In the patients who are asymptomatic or minimally symptomatic, you could consider a sipuleucel T. So this is an immunotherapy approved for prostate cancer. It's approved for patients with non-visceral or non-visceral asymptomatic or minimally symptomatic M1 disease. Palliative radiation therapy should be used along with it for symptomatic bone metastases. T cells are harvested, they're cultured and stimulated, reinfused IV 3 days later. This is given as 3 cycles, 2 weeks apart for 6 weeks total. The downfall with this is that it doesn't really decrease the PSA or the radiographic change. So it's really difficult to know when it's working, which can be upsetting to the patient and even the provider. Again, outcomes. So the difference here is somewhat minimal. Going back to our list of agents, so these are all the FDA approvals for metastatic castrate-resistant disease. And just since 2010, you can see how many we have. So when I'm counseling patients who are being started on treatment early in the disease process, I always tell them we have an arsenal of agents that we can use. So once one starts to fail, we usually have something else that we can use. Docetaxel was the first chemotherapeutic agent that was approved for in 2004. This was approved, and then the AR targeted therapies were next approved with the Abiraterone with prednisone, and then the enzalutamide. This was first approved post-chemo and then also as pre-chemotherapeutic agents. Abiraterone approved for metastatic castrate-resistant disease with or without visceral mets, both pre and post chemotherapy, so if they had docetaxel or not. So it's an androgen biosynthesis inhibitor. It must be given with daily prednisone, twice daily prednisone. Monitor these patients, especially those patients who are on rifampin, the antifungals, HIV meds, seizure meds. The follow-up for these patients is pretty close follow-up, so monitor their LFTs, their electrolytes, their cardiovascular health, and don't be afraid to, like I said, send them back to their cardiologist. For patients with hepatic impairment, mild hepatic impairment, no adjustment is recommended. However, with moderate liver dysfunction, you can dose reduce, and it is contraindication in patients with severe liver dysfunction. This is the follow-up schedule. Again, it's pretty close, careful follow-up. Again, this is actually a really great place for nurse practitioners and physician assistants to monitor these patients. We typically have a little bit more time and we're able to follow up on the labs for them. Enzalutamide was approved for metastatic castrate-resistant disease with or without visceral mets. Again, both pre and post chemotherapeutic agents or patients were able to be enrolled. Competitively binds the androgens and prevents the translocation of the androgen receptor. The dosage is 160 milligrams daily. Does not require a prednisone administration as well. This is also contraindicated in patients with severe hepatic impairment. Also caution in patients with seizure disorder, head injury, or stroke. And then multiple drug interactions are present with this medication as well. Avoid use with the patients who are on some of the agents that are listed here. And patients who are on warfarin or immunosuppressants need to be monitored a little bit more closely. You can see here, so it's a balancing act, deciding when to administer abiraterone or enzalutamide and when to start patients on these agents. Chemotherapy in advanced prostate cancer. Cytotoxic chemo was long felt inadequate for prostate cancer. Some of the agents were approved for palliative benefit only. And like we mentioned earlier, docetaxel was the first chemo to show survival benefit in prostate cancer. And its indication was for metastatic disease patients who were failing other therapies. Cabazitaxel was approved in 2010 for metastatic castrate-resistant disease who were failing docetaxel, so as second-line therapy. The radioisotopes are used for patients with bone mets. The most common that we see is radium-223 that shows the most benefit. These agents target new bone growth in and around the metastases. Radium-223 demonstrated both symptomatic improvement and survival benefit. So patients could receive this post-chemo and in the chemo-ineligible space. It's given as 6 monthly injections total. So going back to those NCCN guidelines for metastatic castrate-resistant disease, so the second-line treatments include, for post-visceral mets, the docetaxel with prednisone, Enza, Abiraterone with prednisone, of course, alternative chemotherapies, cabazitaxel, pembrolizumab, and clinical trials. So where are we going? Combination therapy is certainly a question, and which combinations should we use? And then the correct sequencing, which agent should we give first? Other agents, of course, are the PARP inhibitors, the new anti-androgens targeting the splice variants, the radioisotope therapy. And then why do the CTLA-4 and PD-1 monotherapy work? I'm sorry, why don't they work in metastatic disease patients? Because we're talking about cold versus hot tumors. T cells are excluded from most prostate cancers, so they don't typically respond well to the immunotherapy agents like some other cancers do. So you can see here a list of a lot of the cancers that we see when we're seeing patients, and prostate cancers they're just not responsive or not typically responsive. So some of the novel directions: vaccines plus PD-1, combination checkpoint inhibitors, targeted therapy plus PD-1, cytokines, and others, of course, that we haven't even examined here today. Genetics, of course, is playing a bigger and bigger and bigger role in patients with prostate cancer. And so the role of genetic testing for inherited prostate cancer risk was evaluated in the Philadelphia Prostate Cancer Consensus Conference in both 2015 and 17. And they evaluated when should we do genetic testing. So agreement was moderate to test all men who presented with metastatic castrate-resistant prostate cancer, regardless of family history. We've really only just touched upon the germline mutations that are present in patients with prostate cancer, especially with metastatic prostate cancer. But we do know, especially BRCA2 is present in a large portion of these patients. And more so, we know that germline mutations are present in nearly 12% of patients with metastatic disease and 4.6% with localized disease. The take-home points from this consensus were that, prostate cancer adapts in the castrate microenvironment. Germline mutations, again, are present in nearly 12% of metastatic disease patients, and advanced prostate cancer harbors clinically actionable molecular alterations. So what can we do as APNs, so NPs, PAs? Again, routine screening, labs and scans, making sure patients are compliant, administering the treatments, managing the toxicities of the treatments, and making sure they're sticking to their oncologic follow-up. Now we're moving on into bladder cancer. So I'm going to turn this over to Dr. Trabulsi.
Thanks, Anne. And I have to remember how to, there we go. Okay. So thanks, Anne and Costas, for allowing me to be a part of this course. And thank you to AUA for continuing to support our course. As Costas mentioned, this is the 5th year we've given this. So I'll transition now to bladder cancer. And here's a schema of some of the topics that I'll be talking about. As we all know, bladder cancer does have a significant burden in the US adult population. It's got both a high incidence and a high prevalence. So more than 83,000 new cases per year in the US, almost 20,000 deaths. It's more common in men, and it represents the 4th most common malignancy amongst American men. And as I mentioned, the prevalence is also very high. So there's lots of men that are, patients that are living with their cancer because the majority of them at presentation are superficial. So the estimate of about 10-fold higher prevalence than the incidence, so hundreds of thousands of patients in the US with bladder cancer. Tends to be a disease of the older, average age of 68, and it does translate, unfortunately, to nearly 10,000 radical surgeries every year. When we talk about urothelial cancer or bladder cancer, the vast majority of bladder cancers are urothelial cancers. We need to define what specific risk the patients are in. So we categorize patients as either non-muscle invasive or muscle invasive. And then the non-muscle invasive we categorize as low or high risk. So low risk patients are usually papillary tumors, non-invasive tumors, and no evidence of invasion. The high-risk non-invasive tumors are the ones that have either superficial invasion, which is high-grade T1, or carcinoma in situ. And then the muscle-invasive patients, those are the highest risk for metastasis and demise from bladder cancer. So focusing specifically on the superficial or the non-muscle invasive bladder patients, we use different risk stratification schemas. The AUA has an excellent one. This is on the AUA website. And so we look at, as I mentioned, the size of the tumor, the degree of invasion, the unifocal or multifocality, recurrence patterns, and the presence or absence of carcinoma in situ to categorize patients into low, intermediate, or high risk. The high risk patients are the ones that are high grade and recurrent or high grade and superficially invasive. The variant histologies, such as nested variant, which is becoming more prominent, or small cell neuroendocrine tumors. And then carcinoma in situ, by definition, is a high-risk patient. This is a very complicated schema, but it does show the important finding that there are fairly well-defined algorithms based on the risk profile. So low risk, intermediate risk, and high risk. This is a consensus algorithm from the AUA and the SUO. It's complicated, but it's easy to follow. And so as you're following patients, and when I see patients coming in, I'll have a office cysto day. I'll usually have the NCCN and AUA guidelines open on my computer, see where they fit, and make sure I'm following the guidelines. A mainstay of therapy for superficial or non-muscle invasive disease are intravesical therapy. We've been using intravesical therapy for almost 50 years, primarily with immunotherapy, and then also more recently with chemotherapy. There's certainly strong evidence supporting perioperative chemotherapy. So the idea of giving an intravesical chemo treatment right after a resection in the PACU or in the recovery room for about a 45-minute to 60-minute dwell time. And that definitely has been shown to decrease the recurrence rate. The idea is that the act of us biopsying patients may liberate tumor cells that have the chance to sort of implant and land in other areas of the bladder and turn into tumors later. So postoperative chemo, theoretically, hopefully would sort of sterilize the urine and prevent that. In the office setting, beyond the post-op setting, is where we start thinking about BCG. And that's the primary immune therapy that's been used in bladder cancer for, like I said, almost 50 years. It's a non-specific immune adjuvant. It's a close relative to the tuberculosis bacterium. I'm not sure who ever dreamed of putting this in people's bladder, but it's really sort of the model initial form of immune therapy for oncology. And it remains the gold standard. It reduces both the two aspects that we want to reduce for bladder cancer, superficial bladder cancer, both the risk of recurrence and, more importantly, arguably, the risk of progression. It does have some symptoms, usually mild in terms of irritative voiding symptoms. Very rarely you can get systemic BCG infection. And so that's something that we counsel patients about. And there also is strong evidence that beyond the induction, that giving maintenance BCG to periodically re-stimulate the immune system enhances the benefit. How does it work? It's probably a combination of different pathways. I'm not sure if anyone knows exactly how it works. It's a combination of innate immunity and cancer destruction, adaptive immunity. But basically what I tell my patients is it sort of revs up the immune system, kind of like a forest fire, to get rid of the bacteria, and it gets rid of any cancer cells in its wake. The typical sort of schedule is a 6-week induction. We do try to make sure as best we can that the patient can hold it in their bladder for 2 hours. So if the patient is a big coffee drinker or takes diuretics, we might counsel them to avoid it or delay their diuretics till after the treatment. We do counsel them on the importance of sterilizing the urine with bleach and to avoid barrier contraceptives if they're sexually active. The maintenance schedule is usually an abbreviated course, 3 weeks instead of 6 weeks. You also can reduce the dose, especially if patients that don't tolerate it well, or in our current BCG shortage environment, we've been forced to use reduced doses to sort of make more drug available for a larger group of patients. How much does the reduced dose and the maintenance impact things? When you look at a meta-analysis, there does seem to be concerns that reduced dose does lower the efficacy, but does not eliminate the efficacy. But it's one of the realities, unfortunately, of our current environment of BCG shortage. And the BCG shortage, unfortunately, has been going on now for several years, to the point where AUA was very proactive and came out with a consensus document and different strategies to sort of ration BCG. The first one is that BCG should not be used for patients that are in the low risk category. Those patients probably could be observed or maybe would benefit from the intravesical chemotherapy. If patients have the very highest risk features, we should try to prioritize them to full strength BCG. But again, if it's not available, reduced dose at half or 1/3 dose can be used. And then the maintenance schedule has also been relaxed in the face of BCG shortage, again, to try to make the drug available. The important thing is, though, that certainly on the high risk end of the spectrum, we might want to be more aggressive with surgery if we're really concerned about their ability to receive BCG because of supply issues. The definition of failure of BCG has also been somewhat confusing, and there's been a relatively recent attempt or definition schema to try to categorize patients that have recurrence after BCG. So the first thing that the consensus group identified is that what adequate BCG entails. You need to know how much BCG they've received to decide if they're really failing it. And so the consensus schema of definition of adequate BCG is either 2 full induction BCG courses, 6 weeks each, or induction plus maintenance. So at least 5 out of 6 induction and 2 out of 3 maintenance. So if they haven't even received that much BCG, it's really probably inappropriate to call them a failure. And then we've come up with 4 different categories based on the pattern of recurrence. The overarching term is BCG refractory, which we used to use. We're trying to retire that and really categorize patients as either BCG relapsing, BCG intolerant, or BCG unresponsive. So relapsing patients are the ones that did achieve a disease-free state. So they had cystoscopy and/or biopsy that was negative and then recurred 6 months or later after their BCG. The intolerant is those patients that were unable to complete BCG because of side effects. And then BCG unresponsive combines the refractory and the relapsing, either 6 or 12 months based on whether they had papillary disease or CIS. The importance of these diagrams or these definitions are that these are the definitions that FDA is looking at when evaluating novel agents for approval. So this has become a fairly common template that different novel agents are being investigated on in terms of defining if they're unresponsive and what their response rates will be. Looking at salvage options for those that failed BCG, certainly repeating the BCG makes sense, especially if they've had a disease-free interval. So that would be more like the BCG relapsing. Surgery or chemoradiation for the invasive tumors, and then intravesical cytotoxic chemotherapy has really become the most common salvage agent outside of a clinical trial. Valrubicin was approved several years ago, specifically for refractory carcinoma in situ. The response rates are not great, about 16%. Gemcitabine with or without docetaxel has become our default for chemotherapy, second-line intravesical therapy. When you look at the post-op, there was a recent study looking at gemcitabine versus saline, a sham injection after resection, and looking at the gemcitabine group versus the saline group and the recurrence rates. And the recurrence rates were significantly reduced in the patients that received post-operative gemcitabine. So this has been a little slower on the uptake, especially amongst community urologists, probably because of resource constraints. But we generally advocate to try to consider post-operative chemotherapy nowadays, usually mostly with gemcitabine for patients with papillary disease that appear to be fully resected. And when you looked at the 4-year recurrence rates with low-grade non-muscle invasive urothelial cancer, there was a significant reduction of recurrence. Immune checkpoint inhibition, we're going to talk about this quite a bit in the metastatic population, but it also has a relatively new role in the superficial, the high-risk non-muscle invasive bladder cancer patient, specifically pembrolizumab, which is an anti-PD-1 antibody. This was approved in January 2020 for high-risk BCG unresponsive non-muscle invasive disease of carcinoma in situ with or without papillary disease. This was based on the KEYNOTE trial of 148 patients, showing a complete response rate of 41%, which is higher than historical controls, with a fairly durable duration of response of greater than a year. Switching gears a little bit to muscle invasive disease, this is a schematic of the lining of the bladder. And so the inner urothelium is the most superficial lining. This is where the tumors start. If it has the biological ability to grow through the lamina propria and hit the red muscle wall of the bladder, those patients have a significant detriment to survival. These patients need very aggressive therapy. So this is clinical stage 2 or stage 3, diagnosed on a transurethral resection. These patients will be staged for their abdomen, chest, and occasionally a bone scan, especially if they're having any bone pain or symptoms. These patients generally will require very aggressive therapy, either cystectomy, especially those patients that are healthy and are able to undergo a major surgical procedure, or in chemoradiation for those that are not surgical candidates. So the role of neoadjuvant therapy for bladder cancer became very clear in the early 2000s. This seminal New England Journal article by Dr. Grossman investigating neoadjuvant chemotherapy plus cystectomy compared with cystectomy alone. This looked at 3 doses of standard MVAC followed by cystectomy versus cystectomy alone. And this standard MVAC in the early 2000s was a fairly toxic regimen. Nowadays, we've replaced it with accelerated MVAC or dose-dense MVAC, and also use growth factor support. It's much more tolerable. But even with that, there showed a significant survival benefit in patients that got neoadjuvant chemotherapy compared to cystectomy alone. Most importantly, when you looked at subgroup analysis, the patients that achieved a complete pathologic response was significantly higher in the patients that had preoperative MVAC, 38% versus 15%. This sort of shows that an aggressive TUR can completely eliminate visible tumor from the bladder alone. It's important, though, because this is also an important endpoint that we're looking at for future neoadjuvant trials, because it seemed like the patients that achieved the pathologic T0 appeared to get the most benefit in terms of overall survival. So there's been a host of similar trials looking at neoadjuvant cisplatin-based chemotherapy neoadjuvant strategies for invasive bladder cancer. Cisplatin doxorubicin, MVAC, and in general, they're all fairly consistent, showing improved survival in patients that get preoperative chemotherapy. We were participants with Dr. Plimak and Fox Chase in a neoadjuvant phase 2 trial of dose-dense MVAC, followed by cystectomy. And this was a similar schema to the old Grossman SWOG protocol with postoperative dose-dense MVAC, 3 cycles, followed by repeat staging, and then radical cystectomy. The dose-dense MVAC is a very accelerated schedule. The cycles are only 2 weeks. So the time to surgery was only about 10 weeks, which is very accelerated. 6 weeks of chemo, and then usually we gave them 3 or 4 weeks to recover. And similar sort of complete pathologic response rate of 38%. Another endpoint that is commonly evaluated in clinical trials is the pathologic response rate of T1 or less, so no residual muscle invasive disease, and this was a significant, almost half the patients had that benefit. 65, almost 2/3, 65% of patients were clinically downstage compared to their upfront clinical stage. So the question we always get, and this is a slide that I borrowed from Jeannie Hoffman-Sensitz, who used to be with us here at Jefferson. You know, when do we give chemo? And so one of the concerns with neoadjuvant is that if they're one of the tumors that doesn't respond, we're automatically delaying their potentially curative surgery. Why not use their final surgical pathology to guide treatment? But as the medical oncologists have observed, the patients that get neoadjuvant chemotherapy and then go to surgery definitely appear to do better in terms of quality life, performance status, than the patients that have upfront cystectomy, get a bad pathology, and then they're trying to give chemo. And there's a significantly higher risk or concern that the patients that potentially would benefit from chemo postoperatively never get chemo because of delays in treatment related to surgery. So the timing really does seem to matter. And this is evidenced here, and that adjuvant chemotherapy has the potential benefit that we wouldn't necessarily overtreat patients. Patients may not need it, but upwards of 30% of them will not get chemo. And there really hasn't been randomized clinical trials that show the same level of evidence for adjuvant therapy that the neoadjuvant trials do. This is one trial from Europe looking at adjuvant chemotherapy or for bad pathology, so T3, T4, or node positive, or deferred 6 cycles of chemotherapy if and when they relapsed. It didn't accrue very well and the trial closed early. Looking at these patients that actually went on trial, it did appear that the adjuvant patients did better than patients who'd received treatment at the first determination of metastasis. So there is a role for adjuvant chemotherapy and should be considered in the patients that don't get upfront chemotherapy but have an adverse pathology after cystectomy. And here you can see a ASCO clinical practice guideline looking at invasive and metastatic bladder cancer. I highlighted takeaway points 2 and 8. So neoadjuvant chemotherapy is recommended, and it should be cisplatin-based chemotherapy, not carboplatin. And then for first-line therapy of metastatic disease, again, cisplatin-based chemotherapy should be considered. And as I mentioned earlier, the pathologic downstaging definitely appears to show, those patients appear to show the most benefit. And this has been confirmed on multiple different trials. So the patients that have ideally T0, N0, but less than T2 as well, appear to get the most bang for the buck. So what about preoperative immune checkpoint inhibitors? There have been trials looking at preoperative pembrolizumab. This was the PURE study. And this was patients that are cystectomy candidates that have a good GFR, and they were randomized. This is a non-randomized trial, excuse me. Again, got 3 cycles of pembrolizumab and then cystectomy. The majority of them were cisplatin eligible. And you could see a pathologic complete response rate in these patients almost identical to what we see with cisplatin combination chemotherapy, neoadjuvant therapy, of almost 40%. So our clinical guideline, our clinical practice, we use neoadjuvant dose dense MVAC or gemcitabine cisplatin prior to cystectomy for patients that can get cisplatin-based chemotherapy. We have used neoadjuvant pembrolizumab as well, much more selectively. Patients that potentially are bulkier, that we're worried more even if they don't have metastatic disease. This is an open area of research. Transitioning now to the metastatic population, this is where immunotherapy has become so vital. And this, frankly, is very confusing. But if you look at the interaction between the regulatory T cells and the tumors, and this PD receptor, PD stands for programmed death. It's very dramatic. And the typical, sort of baseline is that if PD binds to the PD ligand, which is present on the tumor cell, that's actually inhibitory on the T cell, and it downregulates T cell activity. So if you can block that interaction, it actually will sort of block the inhibitory effect on the T cell. So the very simplistic way of thinking about this is we have the gas and the brake. And if we can let off the brake and step on the gas by enhancing the cytotoxic T cell activity and minimizing the T cell downregulatory or inhibitory response, we get enhanced immune recognition of these tumor cells and enhanced immune attack on these tumor cells to get rid of them. So when we have T cells and antigen presenting cells, there's lots of different targets for which antibodies have been delivered, again, to try to step off the brake and step on the gas. So if we look at NCCN guidelines for first-line therapy for locally advanced or metastatic urothelial carcinoma, as I mentioned, cytotoxic chemotherapy remains the preferred first-line regimen, all of which would include cisplatin-based chemotherapy, not carboplatin, so either MVAC or gemcitabine cisplatin. A newer sort of approval has been avelumab, which is one of the immune checkpoint inhibitors. And we'll get into this a little bit later, but maintenance therapy with immune checkpoint inhibitors after cisplatin-based chemotherapy does appear to improve survival. For the patients that are cisplatin ineligible, we have a variety of different options. Gemcitabine plus carboplatin, pembrolizumab. Atezolizumab is listed here, but interestingly, after this February NCCN guideline, the atezolizumab confirmatory study came back non-significant, and so atezolizumab has been withdrawn for first-line cisplatin ineligible in this guideline. So who is cisplatin ineligible? This is another sort of murky combination of patients. Performance status, creatinine clearance, hearing loss, neuropathy, and heart failure are the big ones that go into the mix in terms of defining a patient cisplatin eligible or ineligible. And as you may imagine, from an older patient population, upwards of 50% of patients are not eligible for cisplatin. So here's a really, I think, telling slide of the landscape of urothelial carcinoma. Cisplatin was approved in the late 70s, and then we had this huge wasteland, no new agents approved until gemcitabine got approved in 2008. And now recently we've had a flurry of new agents approved in the metastatic urothelial carcinoma patient population. So right now, as terrible a disease as bladder cancer is, this is a really exciting time for advanced bladder cancer, where we went 20 years, 30 years with 2 drugs approved, and now we have all of these different drugs approved with more on the horizon. So what are the sort of the current unmet needs? Certainly in the platinum eligible patients, we do have fairly good treatments, not perfect, but we do have agents. The platinum eligible patients, though, really do not have as much options for them. This is an area of unmet need. When we look at the sort of guideline-based management of metastatic disease, the first sort of fork in the road is, are they eligible for cisplatin or not? And unfortunately, patients that are not chemo eligible, this is when we're thinking about hospice or best supportive care or clinical trials, or perhaps the immune checkpoint inhibitors. For the chemo eligible, again, gemcitabine, cisplatin, or MVAC with avelumab maintenance is now the current standard of care. And this is the Javelin trial, relatively newly reported, showing the benefit of maintenance therapy with checkpoint inhibition. So these patients that had some response in the metastatic population, either a CRPR or stable disease with first line cisplatin-based gemcitabine, cisplatin or gemcarbo, or the unresectable locally advanced patients, they were randomized 1-to-1 to avelumab or a best supportive care alone. And this did show a survival benefit with the maintenance of PD-L1, a significant survival benefit. So this has now become a new standard for metastatic disease. Looking at the NCCN guidelines for second-line therapy, second-line, the preferred regimen would be pembrolizumab. You can look at second-line chemo agents. This is where we get into other immune checkpoint inhibitors, and then other agents such as erdafitinib or enfortumab. And again, another schematic, second-line therapy. After chemotherapy, we would look at their FGFR mutation status. This could guide whether erdafitinib, which I'll talk about later, newly approved in the FGFR positive population, FGFR negative after chemo, again, pembrolizumab or the different immune checkpoint inhibitors is the standard of care. If they're failing the immune checkpoint inhibitors, if they've never received chemo, it's not unreasonable to try chemo on that. If they're ineligible, we can think about second-line chemotherapy or other agents or clinical trials. We can see that there's been several different trials looking at second-line post-platinum, and this is the trial that I mentioned, the IMvigor, atezolizumab, and also durvalumab. The phase 2 showed benefit and led to FDA approval, but the confirmatory phase 3 did not, and these were withdrawn. So enfortumab and erdafitinib are preferred agents based on second or third line or greater. And then there's been a new addition to this last month. I'm not going to try to pronounce this, but this is an agent that is currently available for breast cancer patients. It's an antibody drug conjugate targeting trophoblast cell surface antigen 2 or TROP2. This was approved on the basis of the Trophy U01 phase 2 trial, heavily pretreated patients failing chemo and checkpoint inhibition, showing an overall response rate of 27%. And even in this heavily pretreated patient population, a complete response rate of 5%. So how are we doing in the advanced urothelial carcinoma population? We're not doing so well. There are agents, we've talked about all these different agents. When we look, if we have 100% of patients with newly diagnosed metastatic disease, only about half of them receive standard first-line therapy, only 17% receive second-line therapy. So there's lots of areas of unmet need and areas for improvement. Speaking specifically for sort of heavily pretreated patients, this is where we get into enfortumab, erdafitinib, and the newer agents. You can see here a complicated schematic of different inhibitors in red and stimulators in green. These are all drug targets with active investigation. Okay, let me get back here. So all of these different trials in progress looking at combinations of PD-L1 with chemotherapy in the neoadjuvant and metastatic population. So speaking specifically about erdafitinib, this is an oral FGFR inhibitor. This is approved for second-line metastatic urothelial cancer after chemo that has an FGFR alteration, an overall response rate in 32%, with a partial response in 30%, and there are some complete responses. About 20% of patients in this population will have FGFR mutations. You can get that on tumor or foundation testing or that sort of next generation sequencing. And enfortumab, I've mentioned a couple times, this is an antibody drug conjugate that delivers a cytotoxic drug to cells that express Nectin-4. This is a transmembrane cell adhesion molecule. This is expressed in the majority of urothelial cancer patients, 83%. This is approved in the third line, and there's current studies ongoing looking at a combination of enfortumab with pembrolizumab. And then this new TROP2 antibody drug conjugate, as I mentioned, has recently been approved, again, in the heavily pretreated patient population. Speaking very briefly about upper tract disease, it's an uncommon malignancy. We extrapolate a lot of our treatment strategies from the bladder cancer literature, and you can argue whether that's appropriate or not. It is urothelial in origin, so there isn't any reason to think that it should be dramatically different. ECOG Akron, led by Jeannie Hoffman, Sensits, completed a phase 2 trial of neoadjuvant dose-dense MVAC, similar schema to neoadjuvant prior to cystectomy. They showed a 14% complete response rate after dose-dense MVAC. And as I mentioned, downstaging to T1 or less of 60%, which we think does have some clinical significance. On the adjuvant side, the POUT trial looked at adjuvant gemcitabine cisplatin or gemcitabine carboplatin that showed improved disease-free survival. One of the things that we have to keep in mind on the upper tract tumors, perhaps maybe a little bit more urgency to think about neoadjuvant therapy, is that by definition, these patients are going to have less nephrons after surgery, after their nephrourectomy. So they may be chemo eligible pre-op, but chemo ineligible post-op. So there is a real need, and ECOG Akron is opening a follow-on study looking at dose-dense MVAC in combination with checkpoint inhibition to try to boost this complete response rate. That'll be coming down the pike soon for the upper tract patients. And with that, I will turn it over to Dr. Lawless. Thanks a lot.
Thank you, Ed. I am going to get started in 1 second. I'm going to complete our talk today talking about renal cell carcinoma. A quick overview and the epidemiology of renal cell carcinoma. About 2 to 3% of all cancer deaths in the US each year. The median age is of diagnosis is about 65, and with a median age of death about 70. The rate does increase about 2% per year over the past 65 years. 90% of the tumors are renal cell carcinoma, with the vast majority of those being clear cell. Certainly stage drives survival, with stage 1 having a very favorable outlook and stage 3 and 4 disease being a lot more dismal. As far as risk factors go, smoking and obesity are 2 of the possible preventable risk factors. And then there is hereditary type renal cell carcinoma syndrome, such as von Hippel-Lindau disease. At this point, surgical resection remains the only effective therapy for clinically localized renal cell carcinoma, although there are some ablation techniques which we will not be getting into today. 2020 kidney cancer statistics for both men and women. Kidney and renal pelvis tumors are in the top 10 as far as estimated new cases go. However, a testament to how effectively, especially the early stages, can be treated. They fall out of the list for both men and women when it comes to mortality. The histologies I already mentioned. There's clear cell, which is the most common type. Papillary, type 1 and type 2 are the second most common types, with type 2 being the more aggressive. Chromophobe renal cell carcinoma is thought to be more indolent. And then we see less common and much more lethal variants, such as medullary and collecting duct tumors. I will not be speaking of urothelial, upper tract urothelial carcinoma, as Ed covered that a little bit in his talk himself. Certainly difficult to judge on imaging. But sometimes pathologically we'll see benign tumors 5 to 10% of the time, with the most common types being oncocytoma and angiomyolipoma. This is what they look like under the microscope. Clear cell has that very classic clear cytoplasm pattern with the associated mutations being VHL. And I put the associated mutations for the other types of cancer on this table as well. Again, papillary type 1 and type 2 are the second most common, with chromophobe. And I put oncocytoma here. You get a crossover of these in patients with Birt-Hogg-Dubé syndrome. As I mentioned, staging really drives the survival for these patients. And thankfully, most of the patients present with localized tumors, either stage 1 or stage 2, although you can see locally advanced tumors and distant metastatic disease. And conventional teaching is that approximately 1/3 of patients who present with renal cell carcinoma actually have metastatic disease at presentation. As we've been taught, renal cell carcinoma is dismally responsive to chemotherapy. There have been several trials with several patients looking specifically at this question, with an overall response rate of only about 6%. There is some limited data that shows a response in the non-clear cell metastatic renal cell carcinoma to agents such as carboplatin, cisplatin, plus gemcitabine. So, and I'll go over these actually much later on in our NCCN guidelines. So over the last 4 decades, although modest, there has been slow improvement in survival stage for stage who patients present with renal cell carcinoma. The 1-year survival is the blue curve, and the 5-year survival is the yellow curve. So in this attests to better therapies and better tolerated treatments, especially for advanced and metastatic disease. We've known for a long time that renal cell carcinoma is an immune rich type of tumor. Some evidence for this includes that there have been anecdotal spontaneous remissions documented in patients who present with large clinically supposed renal cell carcinoma. There is an active abscopal effect in renal cell carcinoma where you see a regression of metastases after treatment of the primary tumor. We see an increased risk of cancer in the immunodeficient states, such as patients who've had transplants and are on immunomodulatory medications, or in patients who have disease states that render them immunodeficient. Also, tumor infiltrating lymphocytes are richly present within tumors, particularly clear cell histologic subtypes. And there have been many experimental therapies that are targeting these actual tumor cells as a result. So looking at the history of treatment of renal cell carcinoma in the decades going back to the 80s up to the early 2000s, that was considered the cytokine era, where there was not really much thought to be available for treatment for patients with metastatic renal cell carcinoma. The ones that were talked about the most were interleukin-2 as well as interferon. And when you go to the NCCN guidelines from this time period, it's actually quite simple, even though it's a busy looking slide, because really what was recommended was IL-2 and interferon, and that was what was in the armamentarium at that time. However, starting in the early 2000s and extending up into the decade that we're in, that we just left right now, so about 2015, 2016, that was the advent of the targeted therapy era. And there were many agents that were approved in that era. And really, the targeted era was based on the discovery of the role of the VHL gene, von Hippel-Lindau gene, in the development and aggressiveness of renal cell carcinoma. And it's been shown that inactivation of the VHL tumor suppressor protein in turn leads to accumulation of a HIF transcription factor, which in itself leads to overexpression of a number of genes, which include VEGF, which drive the aggressiveness of renal cell carcinoma. And the importance of VEGF in the aggressiveness of renal cell carcinoma and its effect upon survival is demonstrated in this slide, with VEGF positive tumors having a much poorer survival rate than VEGF negative tumors. And this was elucidated back in the early 2000s. So as a result of knowing this information, there were several studies that elucidated the pathways of some of the VEGF and growth factor related factors and their role in the development of aggressiveness in renal cell carcinoma. And as a result, there were multiple medications that were developed to target these factors and block them before they were able to wreak havoc on the actual tumor. So on the left here, so the left panel, I show FGFR, VEGF, PDFR, as well as AXL and CMET. And then going over to the right, I'll talk about immune checkpoint inhibitors a little bit later, but the mTOR pathway was also elucidated with its own set of medications serving to block that as well. So, and this was the targeted era of treatment of metastatic renal cell carcinoma, really demonstrated well in this slide. So one of the first studies to look at the benefit of the targeted agents was looking at sunitinib. It was compared against interferon. This was a randomized trial that was published back in 2007. And you can see the curves as far as progression-free survival went. What heavily favored sunitinib with a 31% response versus a fairly poor response in the interferon population. However, although the response rate was much in favor of sunitinib, as far as the side effects, that was however much in favor of interferon, as it was discovered that many of the targeted agents, particularly sunitinib, was very, very difficult to actually tolerate, with several grade 3 and grade 4 side effects actually being present. And this is a slide of the dreaded hand-foot syndrome, which is just as painful as it actually looks, and certainly miserable when these patients would actually develop it, and it was very difficult to actually treat. So in the same New England Journal where the sunitinib article was published, so was published an article looking at sorafenib for metastatic renal cell carcinoma. This was the target trial, also using progression-free survival as its primary endpoint. This was randomized, the sunitinib was actually randomized to interferon, sorafenib was randomized to placebo, but also showed a significant benefit in progression-free survival as compared to placebo. And this led to approval of these medications for treatment of metastatic renal cell carcinoma. Now, the interesting thing about the sorafenib trial was that it was a crossover trial. So those patients who did not respond, who were placebo, were unrandomized, and actually re-randomized to receive sorafenib or placebo. And again, those patients showed who had been given placebo and actually had progressed after being given sorafenib showed a clinical benefit as far as survival goes when compared to the patients who remained on placebo after a second randomization. And it was trials like those where brought in the advent of the targeted therapy era, as I've already mentioned, with a number of medications having been approved based on randomization trials, both phase 2 and phase 3 that I've listed here on this study. And as a result, many of these agents were approved both for first and second line treatment for patients with metastatic renal cell carcinoma. However, most of the targeted therapy agents, and I'll talk about this later, were randomized against interferon alpha. And as I've mentioned already, the response rate of interferon alpha was just so poor that it was hard to believe that these agents, which had a more of a target, were going to respond poorly compared to this actual comparator. So one thing that actually was, I think, significant at the time was looking at, again, the side effect profile of the targeted agents, again, sunitinib being the one that I showed earlier. Pazopanib was developed in order to compare with the other targeted agents, not only as far as efficacy goes, but also as far as tolerability goes. And this was a phase 3 trial called the COMPARES study, looking at first-line pazopanib compared against sunitinib as a non-inferiority study. So patients had advanced or metastatic clear cell renal cell carcinoma. They did not have prior treatments. Again, it was a first-line study. They had measurable disease with a decent performance status starting out. Again, they were randomized to either pazopanib or sunitinib, with the primary endpoint being progression-free survival and the secondary endpoints shown below. And they actually hit their primary endpoint, which was non-inferiority from a progression-free survival standpoint. You can see the curves really well overlap each other all the way down for progression-free survival, and then estimated survival. Again, the curves overlap each other, which shows a clear non-inferiority of pazopanib to sunitinib, which is what the investigators were actually looking for. However, I think that the proof of the benefit of this trial was really looking at the adverse events shown in this forest plot, where the vast majority of the patients who received pazopanib actually tolerated it much better than sunitinib. And as a result, pazopanib was thought to be one of the medications of choice in first line for patients who presented with clear cell renal cell carcinoma, simply because of the actual tolerability. Again, talking about the targeted era, these were eventually the drugs that were approved by the FDA for renal cell carcinoma. Again, the targeted agents looking at a variety of targets, including the temsirolimus and everolimus mTOR pathway targeted agents. So not to be Elizabethan about it, but we do believe that we are now entering what we think could be the golden age of metastatic renal cell carcinoma care, starting in 2015 after the targeted agent era, which was thought to be the modern age. And of course, although I'm sure that some of the older members of the audience would agree, the dark ages were thought to be the earlier IL-2 and interferon era. So what does the golden age involve? I've mentioned most of the medications here. This was a slide that was developed in 2020, so actually we will be adding on to that as I go through my talk. So cabozantinib actually, believe it or not, is another targeted agent, but it's been brought into the golden age simply because of the number of targets it actually goes after. And it includes targeting not only VEGF, which is angiogenesis, but also MET and AXL, which upregulation are also associated with a poor prognosis in patients with renal cell carcinoma. The CABASUN trial looked at cabozantinib versus sunitinib in patients who were IMDC rated or classified as poor or intermediate risk. And this was a phase 2 study. Patients were randomized to receive cabozantinib or sunitinib. And again, they have been classified as intermediate to poor risk based on their IMDC classification. The primary endpoint of this was progression-free survival, with the secondary endpoint being overall survival. And again, this primary endpoint is something that we've seen in a lot of the other targeted era studies that I've already shown. And what ended up happening was cabozantinib certainly outperformed sunitinib in this particular patient population, with a median progression-free survival of 8.2 over sunitinib's 5.6 months. The rates of adverse events were actually very similar between the two. Again, they're both considered targeted agents. And this was believed, again, as opposed to the pazopanib trial, this was the first study to show an agent which demonstrated superiority to sunitinib. Again, it was a targeted agent versus a targeted agent. And at the time, cabozantinib was approved for first-line treatment of metastatic renal cell carcinoma, particularly in patients who were IMDC classified as intermediate or poor risk. And then came the checkpoint inhibitors. This was published in 2015. It looked at nivolumab, comparing it to everolimus in patients with advanced renal cell carcinoma. This is in patients who had been pretreated, so it's second line and beyond. Most of these patients had received already one of the targeted agents, and now they were going on to receive a second targeted agent, although probably a different pathway, and they were randomized 1-to-1. And showing the curves here, nivolumab did outperform everolimus with a hazard ratio of 0.57. And I think even more significant was the fact that it was much better tolerated than the everolimus. Again, now you're comparing the immuno-oncologic agents versus the targeted agents, and you saw a 19% grade 3 or 4 treatment-related adverse events in the nivolumab population versus 37% in the everolimus population. And then this was a article looking specifically at combined PD-L1 or PD-1 as well as anti-CTLA-4, so two different immuno-oncologic agents, nivolumab plus ipilimumab, again, comparing it to sunitinib in patients who also had intermediate or poor risk disease. Again, patients were randomized 1-to-1. And the 18-month overall survival going on, and I think something that's significant here is that overall survival was one of the primary endpoints along with progression-free survival. And you saw that patients who were treated with nivo-ipi certainly outperformed sunitinib, both for overall survival as well as progression-free survival. The overall response rate was 42% in the combined immuno-oncologic arm versus just 27% in the sutent arm. And I think even more significant was the fact that there were 10% complete responders in the combined immuno-oncologic arm versus just 1% in the sutent arm. And again, looking at the adverse events, something that I've driven home already today, the agents are different. So you saw a lot less grade 3 and grade 4 adverse events in patients who received the combination of checkpoint inhibitors versus patients who received the targeted agents. Also, the discontinuation as a result of the therapies favored the immune checkpoint inhibitors because of the tolerability question. And it was a result of this study that, again, these were first-line patients, so patients who had not been pretreated, that ipi/nivo was approved for first-line, in this case, intermediate to poor risk of metastatic renal cell carcinoma. And the one thing about this trial is that when you look at the IMDC classification of these patients, even though the immuno-oncologic combination therapy outperformed Sutent with regard to the intermediate and poor risk patients, really with the favorable risk IMDC patients, Sutent still actually showed benefit. So the combination therapy did not cover all IMDC classes as a result. However, stay tuned. So just one word on IMDC. This is how it's calculated. And one thing that I'd like to point out, which I do talk to all of my trainees about as well, is that when looking at all the criteria used to risk stratify patients with regard to the IMDC category system, about 80% of them who are being selected for first-line treatment for metastatic renal cell carcinoma are already being classified as intermediate or poor risk. So the vast majority of the patients who are coming in with metastatic renal cell carcinoma who are untreated are going to be considered intermediate or poor risk. So at least by the study that I just showed you, they're going to they're favorably treated or more favorably treated with the combination of immuno-oncologic agents. Now, so we have two classes of medications. We have the targeted agents, we have the immunotherapies, and there was a lot of excitement about what the thought of was when you combined the actual two of these. And there have been some studies that have just been reported out on these combination trials, which have been very favorable, which I'll show right now. This was one of the first ones published in 2019 with Brian Rennie as the lead investigator. Pembro plus Axi, again, versus the comparator of sunitinib for patients with advanced renal cell carcinoma. This was as primary treatment, so untreated patients before patients were randomized for the combination therapy versus single agent targeted therapy, with their primary endpoints again being overall survival and progression-free survival and the intention to treat population. And here are the actual curves. So you saw a significant advantage of Pembro Axi versus sunitinib in this patient population. And I think even more significant is that this was achieved across all IMDC risk groups, regardless of PD-L1 expression. One thing that I think Ed touched on is that occasionally in patients who have increased PD-L1 expression, we see a benefit in treatment with the checkpoint inhibitors, especially the PD-1, PD-L1 checkpoint inhibitors. However, this benefit in this particular study for patients with metastatic renal cell carcinoma was demonstrated across IMDC groups and across PD-L1 expression groups. However, the adverse events, again, now you do have a targeted agent, which is the axitinib combined with the immuno-oncologic agent. So you are seeing adverse events that are similar in the two, although and actually in this particular study, it was a little bit more in the combination therapy as opposed to the single agent targeted therapy group. And again, I think that's because now you're adding another targeted agent in addition to the immuno-oncologic agent. So you're seeing an increase in the actual adverse events. However, because of this study, the FDA did approve Pembro-Axi for first-line treatment, advanced renal cell carcinoma, and then again, this was across all IMDC risk groups. Published in the same New England Journal of Medicine issue as the prior study was this study with Dr. Motzer as the lead investigator, avelumab plus axitinib, so avelumab and Axi, again against sunitinib for patients with advanced renal cell carcinoma. However, this particular study looked at patients, in particular PD-L1 positive patients. So their primary endpoint looked for overall survival and progression-free survival with the biologic stratifier of PD-L1 positivity. Again, the patients were randomized 1-to-1, and these were untreated, so first-line patients. Again, you saw in the patients with PD-L1 positive tumors, you saw a benefit with the combination therapy over the single agent targeted therapy with regard to progression-free survival. And then that was actually held with regard to the overall population. So the second curve down at the bottom here is patients who were both PD-L1 positive and ones who did not have significant PD-L1 staining. Looking at the actual adverse events, it actually favored the combination study, or the combination regimen as compared to the prior study that I showed. Sutent actually did not show a benefit in any of the populations that were actually looked at with regard to actual adverse events. And again, it was because of the study that the FDA went to approve the combination regimen of avelumab and axitinib for first-line advanced renal cell carcinoma, and that approval was done in May of 2019. This was a final study looking at a combination of atezolizumab plus bevacizumab, which is again along the mTOR pathway, again comparing to sunitinib. This was reported out at ASCO back in 2018. This was the Emotion 151 trial, and looking again at the PD-L1 positive patients. Unfortunately, when this was reported out, in the intention to treat population, the endpoints had unfortunately not been reached, although in the PD-L1 positive population, at least at some point, they had been reached. But it was a result of the fact that it had not been reached that Brian Rennie did in 2019 when he presented this updated data at ASCO, believed that atezolizumab plus bevacizumab was not ready for prime time, and really longer term follow-up was going to be necessary to establish whether survival benefit will emerge, and it was not FDA approved as a result. This is the new kid on the block study looking at nivolumab plus cabozantinib. Again, I showed cabozantinib earlier as a multi-faceted targeted agent in the golden era of the treatment for metastatic renal cell carcinoma. So one of the more advanced targeted agents combined with one of the immuno-oncologic agents, looking at it compared again to sunitinib for patients with advanced renal cell carcinoma. This was a phase 3 trial. It was the Checkmate trial. Again, just reported out, patients were randomized 1-to-1, and these patients had not been prior treated. The primary endpoint for this study, like other targeted agent studies, was progression-free survival, with the secondary endpoints being overall survival as far as safety. And here were the actual curves, significant significant advantage of the combination immuno-oncologic and targeted agent regimen versus sunitinib for both progression-free as well as overall survival, with an objective response rate in almost 60% of the patients receiving the combination therapy and just 30% in patients who received sunitinib. Looking at the adverse events, it was higher in the combination therapy, but again, cabozantinib was very difficult to tolerate, but still the numbers were actually very close to the single agent, so not as well poorly tolerated. What I've shown over here in our forest plots are the subgroup analysis of the progression-free and overall survivals. And again, looking across all IMDC groups, and regardless of PD-L1 expression, you saw an advantage of the combination therapy over Sutent. So in January of this year, the FDA subsequently approved the combination of Nivo plus cabozantinib as first-line treatment for patients with advanced renal cell carcinoma. And again, this was across all IMDC risk groups. So where are we in February of 2021? NCCN guidelines for treatment of advanced renal cell and metastatic renal cell carcinoma. Again, this is split up by IMDC group, with the favorable group up here and the poor and intermediate down here. They still have Sutent in the favorable group as a preferred regimen, but and as well as pazopanib, and I showed you that trial earlier. However, some of these combination regimens have now snuck their way in, such as Axi and Pembro and cabozantinib plus nivolumab. In the poor and intermediate risk group, the Ipi-Nivo, which I showed that study earlier, as well as Axi-Pembro, and the cabozantinib and nivolumab regimen are now considered preferred regimens, or just cabozantinib as a single agent. These are going to be second line down here, second line and beyond. And then unfortunately, that was really for all clear cell histology. For the non-clear cell histology, we are looking at really preferred regimens of sunitinib as a monotherapy, and certainly the clinical trial route. One thing that I'd like to drive home is that for all of these, the comparator was sunitinib, and we still have a lack of head-to-head comparisons of the immuno-oncologic regimens, or the combination immuno-oncologic targeted therapy regimens. I'd like to spend a little bit of time on adjuvant therapy in renal cell carcinoma. A little bit of time I think is appropriate, because there's been really nothing to this point that's been shown to be of any benefit, although there are some very promising trials that are currently out and unreported. In this slide, red is bad, yellow is kind of bad, and white at the time of this slide was unreported, although really should be red. And these were all targeted therapies. Assure, S-Track, which was a little bit controversial and conflicting in its actual results, but wasn't really thought to change many practice patterns. And certainly the Everest trial, which was looking at everolimus, turned out to be a negative trial as well. Again, these were all targeted agents in the adjuvant setting. However, there are some agents that are or there are some studies that are looking at the immuno-oncologic agents, Prospera being the one that is, we just tried at our own institution to open it. However, because it's enrolling so well, it's thought to, it's going to be closed actually sooner than projected. So as a result, we didn't even actually open it. So, and a lot of investigators and clinicians are looking forward to the reporting out of the Prosper trial, as well as some of the other trials that I've shown here. One thing that was changed with the Prosper trial is that it used to require a biopsy up front. However, now when patients are randomized, they're being randomized to requiring a biopsy and not requiring a biopsy, then going to registration and getting perioperative nivolumab. That's the medication looked for in the Prosper trial, or going to a partial or radical and then going straight to observation without the administration of any type of adjuvant therapy. And again, we're all looking forward to this being reported out, and it should be closing, I believe, at the end of this year. So right now, in summary, the standard of care for adjuvant therapy does remain observation and surveillance. There are ongoing immunotherapy trials, which I've already mentioned, that are going to be reported out, and we anxiously await those results. A word on metastatic disease and cytoreductive nephrectomy. It's defined as removing the kidney in the face of metastatic disease. It was thought to be traditional dogma for patients who had this. Like I mentioned earlier, as far as the immunogenicity of renal cell carcinoma, spontaneous regression, the abscopal effect has been actually reported. And a lot of this was based on this study here, or these two trials here, an EORTC and a SWOG trial back in the early 2000s that were combined and reported out together, with Dr. Flanagan being the lead author. And again, this was back in 2004. And patients, it was shown who were upfront treated with cytoreductive nephrectomy versus patients who were treated without nephrectomy and with just systemic therapy alone. There was a survival advantage for patients who received cytoreductive nephrectomy. And this study drove the conventional thinking for a number of years that these patients who showed up with metastatic disease should get a cytoreductive nephrectomy prior to being placed on systemic therapy. However, one thing that should be noted when looking at this study is that nearly all the patients who received a cytoreductive nephrectomy, and patients who did not for that matter, did receive systemic therapy. And I think that this point really needs to be driven home. So the role of cytoreductive nephrectomy was looked at afterward with regard to some of the targeted agents. The thought was that it followed that conventional wisdom that cytoreductive nephrectomy was beneficial. However, these were retrospective comparisons. And in fact, there were studies percolating on throughout all of this that demonstrated that in cytoreductive nephrectomy, especially in patients who were really, really poor risk candidates, we actually may be hurting patients more than we're actually helping them, because many of those patients did not go on to receive systemic therapy and actually ended up dying from disease even before they could get to systemic therapy. So you weren't really even doing a cytoreductive nephrectomy, you were doing a palliative nephrectomy, and these patients would go on to die afterward. And that's really borne out in this actual table. Again, poor risk preceding surgery, their survival was much worse than if the patients were of good risk prior to surgery. So the thought was, should we select out the patients who received cytoreductive nephrectomy? And that certainly was borne out in the literature very recently in two separate styles. This is the Carmina trial, looking at patients who were randomized to receive a nephrectomy plus sunitinib versus the sunitinib alone group. And this was a prospective comparison and did show benefit in the sunitinib alone group as opposed to the nephrectomy, cytoreductive nephrectomy, and then going to the sunitinib group. And it should be noted that, again, almost 20% of the patients who underwent cytoreductive nephrectomy never received systemic therapy because they were too sick to get to that point. So again, the thought is, should we select out those patients who we think would most benefit from a cytoreductive nephrectomy? And I think that the SIRTIME trial was much better designed. This really compared, as opposed to cytoreductive nephrectomy versus a nephrectomy with Sutent, just looking straight at sunitinib versus patients who got a deferred cytoreductive nephrectomy. So again, these patients received Sutent up front. The patients who responded got a deferred cytoreductive nephrectomy, and it showed that those patients who had a deferred cytoreductive nephrectomy versus an immediate cytoreductive nephrectomy actually had a survival benefit. So what are the take homes from these trials? Cytoreductive nephrectomy really only improves survival if systemic therapy is delivered. Not all patients who undergo cytoreductive nephrectomy receive systemic therapy, and actually not all patients who undergo a cytoreductive nephrectomy require systemic therapy. So we need to be much more careful about the patients we select for cytoreductive nephrectomy. Patients who progress on systemic therapy upfront may not be the best patients to undergo cytoreductive nephrectomy. Maybe those patients should be the ones that go on to a second line or a third line treatment for metastatic disease versus those patients who respond, who maybe should go on to cytoreductive nephrectomy at that point. As far as the role of the APN, the PA in renal cell carcinoma, really follow-up of scans and labs, I think, are necessary. So thank you for joining us for Chemotherapy and Immunotherapy for the Urologist and Advanced Practice Provider, which is presented by the AUA. Again, I'd like to thank the AUA for allowing us to present our our course in virtual format as part of the kickoff weekend for the AUA 2021. And I'd especially like to thank my colleagues and co-presenters, Drs. Calvaresi and Trabulsi, for another fine year.